I am going to speak about the challenges for the physicians, and my topic is hypercortisolism in type 2 diabetes. Now, all of you know when we talk about hypocortisolism, the thing which come to our mind is Cushing. But what I am going to speak is not Cushing, but other than Cushing, and particularly the area of interest would be subclinical hypercortisolism in the diabetic patients, type 2 diabetics. Now all of us know that stress is one of the precursors and which can really impair the insulin resistance, cortisol secretion, and it can increase the blood sugar values. Now cortisol is a hormone produced by the adrenal gland, is known to raise blood sugar and contribute to the insulin resistance. The 11-beta hydroxysteroid dehydrogenase 1 isoform is expressed in key metabolic tissues such as liver, adipose tissue, skeletal muscle, and its function is to convert inactive cortisol to cortisol, while the isomer type 2 is related to the protection of the mineralocorticoids from the occupancy of cortisol, but also providing the substrate in the peripheral tissue. So both the actions are different about the cortisone and cortisol. Now, hypercortisolism is a clinical state by prolonged exposure to excessive cortisol, also known as Cushing syndrome. Cortisol is a steroid hormone commonly called the stress hormone, and our body releases extra cortisol during the time of the stress, where it can increase muscle tension, blood pressure, heart rate, and cortisol also increases respiration and also inflammation. So all these things are related to excess cortisol production. Now when we look at the prevalence of cortisolism in diabetes, then epidemiological studies show that 6.3% of the patients with type 2 diabetes exhibit biochemical features of hypercortisolism, with prevalence as high as 10.5% in patients having microvascular complications. So there is a significant prevalence of hypercortisolism in type 2 diabetic patients. And if you look at the omnious octet and the role of elevated cortisol, the number of tissues out of 8 organs, 7 organs are affected by the increased cortisol. Now, what exactly causes the hypercortisolism? Then we all know iatrogenic Cushing, use of excessive glucocorticoids, which could be oral, in skin, or even the inhalers. There are pituitary tumors, especially Cushing. There are adrenocortical tumors, adenomas, and again other tumors. And then there are paraneoplastic causes of excess cortisol. Now, all of you know about the features of hypercortisolism and producing Cushing, which is known to all of us, and I am not going to go into the details of this. But importantly, hyperglycemia, hypertension, and osteoporosis, these are the 3 important features which we would keep in mind when we talk about the excess cortisol production. Now, at risk patient population to screen hypercortisolism, the advice by the various bodies is that those patients who have adrenal incidentaloma, there is a prevalence of hypercortisolism to the tune of 50%. So patients with unsuspected tumors discovered in one or both of their adrenal glands, incidentally, we must screen for hypercortisolism. But most important talk is that patients with poorly controlled type 2 diabetes, there is a prevalence of up to 25%, where you can have hypercortisolism. So when you come across the patient who is difficult to control type 2 diabetes with A1C more than normal, with multiple medication, poor glucose control despite insulin, with multiple comorbidities like obesity, hypertension, dyslipidemia, and CVD, high insulin dose requirement, especially prandial, and type 2 diabetic patients above the age of 40, before the age of 40 years, diabetes and hypertension needing 2 drugs for control of hypertension, and diabetes plus hypertension requiring insulin with type 2 diabetes and microvascular or macrovascular complications. These are the type 2 diabetic patients who need to be screened for hypercortisolism because of their prevalence of 24%. Patient with osteoporosis and fragility factors, there is a 10% prevalence of hypercortisolism, and patient with hypertension alone, there is a likelihood of 8% prevalence of hypercortisolism. Now, this August gathering knows how to check for hypercortisolism. So there are a couple of tests which some of are not very accurate and not reliable, cumbersome. So we may ignore those tests like 24-hour urinary cortisol, which is not very useful in the estimation. Likewise, midnight salivary cortisol test also is not very reliable as far as the diagnosing of hypercortisolism. Likewise, sometimes very rarely you may have an ACTH level with high cortisol level. You can find out certain kind of tumors, especially pituitary, in hypercortisolism. But the most gold standard test for finding out hypercortisolism is dexamethasone suppression test, where you need 1 milligram of dexamethasone at 11 p.m. and you do next morning after 8 to 10 hours of fasting and look at the cortisol level along with dexamethasone level, because only cortisol level sometimes may not give you the right idea. So this is very important, and you have to measure the cortisol level along with the dexamethasone level. So these are the things and the things which are very important. Another important test which usually we do 24 hours urinary free cortisol, which also has problems, and you can see here we don't do. So I will skip that, but we will talk about the overnight dexamethasone suppression test, where the reference range, if it is less than 1.8 microgram per deciliter, then it is normal, along with more than 140 nanogram of deciliter dexamethasone level. When the values of 1 milligram dexamethasone suppression test is more than 1.8 microgram per deciliter, along with more than 140 nanogram of dexamethasone levels, these are the standard values which will tell you that this patient has hypercortisolism, and you have to go into the details for finding out the reason for hypercortisolism. The potential factors for false positive are estrogen containing medicines, rapid dexamethasone metabolism with CYP3A4 inhibitors, inducers, dexamethasone malabsorption, failure to take dexamethasone, compliance, use of exogenous glucocorticoids, and chronic renal disorders are giving you the false positive result. While patients suffering from chronic renal disease, liver disease, concomitant medication that inhibit CYP3A4 leading to very high dexamethasone level and cyclic hypercortisolism potentially will give you false negative result. So what is the pathophysiological link between the hypercortisolism and type 2 diabetes? Is that when a person with type 2 diabetes has a chronically elevated cortisol level, it causes resistance hyperglycemia. Cortisol is associated with inflammation in patients with type 2 diabetes who have retinopathy, neuropathy, kidney disease, suggesting that cortisol may play a role in the inflammatory pathway leading to chronic microvascular complications. And prolonged stress and inadequate regulation of the stress system can lead to chronic hypercortisolism, or in some cases a blunted cortisol response to stress contributing to subclinical inflammation, insulin resistance, and increased adiposity, dyslipidemia, and type 2 diabetes. So if you look at the adiposity and dyslipidemia, then increased level of cortisol produces impaired incretin secretion, insulin resistance. It also impairs the protein degradation. There is a low glucose uptake by the muscles. In pancreas, there is a increased glucagon and decreased insulin. In visceral obesity, insulin resistance and dyslipidemia is manifested by cortisol, excessive cortisol, and in liver, there is an increased insulin resistance and increased gluconeogenesis, which further contributes to type 2 diabetes and inflammation. The pathological link between cortisol and diabetic complications are hypercortisolism increases the hepatic gluconeogenesis and reduces peripheral glucose uptake, opposing the insulin action. When we look at the hypothalamus-pituitary axis and its dysregulation, ultimately hypothalamus, pituitary, adrenal axis produces hypercortisolism for various reasons, and that produces diabetes complication. The consequence of untreated hypercortisolism in patients with difficult to control diabetes, patients with type 2 diabetes already face a twofold higher risk of cardiovascular disease at an earlier age, and the coexistence of hypercortisolism in form of autonomous cortisol secretion further amplifies the risk. And there are studies from 2020 natural history study shows that patients with adrenal adenomas and cortical excess who were managed only for comorbidities have significantly higher rates of CV complications in comparison to those who underwent adrenalectomy and had no cortical excess, highlighting that untreated hypercortisolism compounds the cardiovascular burden in type 2 diabetes. And there are studies which shows that global CV events are more in those patients who have diabetes and hypercortisolism, as well as those patients who have diabetes and hypercortisolism, their survival is less. And this is a very important thing which led us to find out hypercortisolism in patients suffering from type 2 diabetes. Now there are various pathophysiological mechanisms like in liver, gluconeogenesis, fatty acid oxidation, adipose tissue, decreased glucose uptake, lipolysis, tissue remodeling is also increased. In pancreas, insulin secretion, glucose sensitivity is decreased, and in skeletal muscle also decreased glucose uptake and glycogen synthesis and etc. So mechanism of glucocorticoid induced insulin resistance and diabetes mellitus in main organs that control the glucose homeostasis, glucocorticoid receptors and other things are responsible. And then many studies have shown that 7 out of the 8 tissue like beta cells, alpha cells, liver, gut, fat cells, brain and muscles are affected by hypercortisolism adversely and produce adverse effects in the control and complications of diabetes. So this slide tells us about that. And mild hypercortisolism by various mechanisms through beta cell dysfunction, proteolysis, lipolysis leads to hypercortisolism. I'll take 1 minute. Process considering for screening, workup and referral for hypercortisolism, as I have already said, that you screen, take the history, do the biochemical test and find out whether there is a hypercortisolism or not, and then refer the patient to some endocrinologist. There are medical therapies which can take care of hypercortisolism, especially for diabetes. The GLP-1s, metformin, SGLT2 inhibitors are useful in glucose metabolism, and there are drugs like pasireotide, cabergoline, adrenal directed drugs and glucocorticoid receptor drugs like mifepristone can be helpful in controlling the cortical related thing. There are therapeutic algorithms which I have already said about the diabetes control in this, and there is a relationship between diabetic microvascular complication. The summary of this study showed that results showed higher serum cortisol levels were associated with greater severity and prevalence of all 3 microvascular complications in form of kidney disease, retinopathy and peripheral neuropathy. Again, hidden hypercortisolism is a subtle cortical excess without even overt Cushing syndrome. Symptoms commonly found in type 2 diabetes patient says that advanced type 2 diabetes, hypertension and insulin therapy significantly increases the odds of having hidden hypercortisolism. So, when a suspect with hidden hypercortisolism type 2 diabetes, meta-analysis also showed that hypercortisolism has an adverse outcome in the management of diabetes. And this was one of the study, catalyst study, which showed that the drug, glucocorticoid receptor drugs, mifepristone, when used, it was helpful in reducing the HbA1c, in reducing the weight, and in reducing the BMI and waist circumference, and that was the study which was done last year and showed promising results. So the take-home message, hypercortisolism, overt or hidden, is common in type 2 diabetic patients. Hidden hypercortisolism increases the risk of CV event, mortality, and microvascular complications. Screening is important in inadequately controlled type 2 diabetic patients, severe hypertension, early onset diabetes, and adrenal adenomas. Untreated hypercortisolism amplifies the cardiovascular risk, microvascular complication, and treatment options include surgery, cortisol lowering drugs, adrenal directed, glucocorticoid receptor antagonist, and optimized antidiabetic therapy in combination tailored to manage the Cushing related diabetes. And Catalyst trial evaluated the role of medical therapy mifepristone in inadequately controlled type 2 diabetic patients with hypercortisolism. So friends, I think I will end here and I am open to any questions if you have. Thank you for your kind listening.